Hey, everybody. Dr. Serena H. Chen and Alice, we're doing one of our Ask Me Anythings, Ask Us Anything. You know, we started off just a second ago getting in touch about and she's getting a lot of questions about timing of embryo transfer and things like that. Here she is. Hello.
Hi. So nice to see you.
It's great to see you. For some reason, I'm not hearing you through my AirPods. I'm going to have to turn.
Can you hear me?
I'm hearing you through my computer, but you're all the way down off my computer, so I don't know what's going on. So.
Is this better?
No, super loud coming through the computer. So, Gloria, we're not going to be able to record on Zoom today because it's going to be too echoey. Okay, sorry, everybody. Here we go. We're just going to stay on Insta. We like to record these both ways so we can also get, push content out on YouTube. But I need to be able to hear. Let me see. Can I talk again, Serena? Let me see if I can hear you.
Testing.
This is super weird. Let's see. Just quick troubleshoot, everybody. And let's see here. We are going to try to get this working. Okay.
Can you hear me now?
I'm still hearing you through my computer and not through my AirPod. Let me try something else. Let's try to wire. Thanks, everybody. Hang in there. Start asking your questions, though. Serena and I are here for you.
Hey, I need to actually mute my computer completely.
Yeah. This is the weirdest thing. I'm gonna leave you on Zoom. I'm gonna go off of Zoom and just talk to you in Instagram, okay?
Okay.
All right, perfect. That was just bizarre. Technology. Isn't it fun? All right, well, good. We got some questions coming in. All right. A couple things that Serena and I were talking about right when we were just kind of prepping for this conversation is, a lot of states like mine in California going back down on full lockdown. And what does this mean for our field? What does this mean for your cycles, for IVF, for IUIs, for assisted reproduction? Because our field was, shut down for 2 months. In the beginning of quarantine, and you're seeing, you were mentioning, Serena, that you were seeing some folks, an increase in your hospitalizations and so forth.
And
so
Governor,
what are you telling people?
If you're in New Jersey, you've been seeing that every day Governor Murphy is putting in place, he's gradually locking down more and more and more. Like 2 days ago, I think we went to less than 100 people for outside gatherings. Now we're down to 25. I forget, and he used to have a list of states that if you traveled from those states, you had to quarantine. Now he threw out the list. It's like anybody
everywhere.
Outside, everybody, you just have to quarantine if you're coming from outside New Jersey.
Right.
And we're seeing, we are seeing a significant increase in transmission rate. They are still saying it's due to gatherings, social gatherings, and not necessarily schools and other and gyms and things like that. So, but I have been getting a lot of questions from patients about will IVF be shut down again, like we were shut down in March. And right now, I'm knocking on wood. I think there are a lot of reasons for cautious optimism. The hospital has a lot of people in there for COVID, but a very small number are really sick. Only a very small number are in the intensive care unit. Very few, only a very small percentage are actually on vents. And a lot of people are in there getting remdesivir, which we know does help with COVID-19. So we talked to a bunch of the other doctors in our hospital system today, and people are feeling like, well, we have more ventilators. We have therapeutics, we have more options, and we are cautiously optimistic that we will not just shut down elective surgery. So right now,
which for the record, we have worked for decades on being treated as non-elective. We are a disease, and fertility is a disease.
The words, you're right, are super important. When they talk about elective surgery in this context, it's not like plastic surgery. I don't like my nose and let's make it cuter. It's more like in it's what they mean is like you're not going to die immediately. It's not.
But that's our frustration, though, right? In the beginning of all of this is when the guidelines came out and when we were lumped into that category. It's the wrong term, hands down.
Right.
It's about non-emergent.
Right.
And there are certain people, though, that certain procedures that if they don't happen, you do lose all your options. So I even struggle with that. It's like, look, if I waited until I turned 45, there's a lot of programs that aren't going to let me do a frozen embryo transfer in their program because of my age alone. There are people who, if they wait 6 months,
Alice.
Okay, good. I'll hand deliver. I would drive my embryos across country if I had to, in like an extra size tank that had a generator in the vehicle if I needed to. I'll do anything to make sure that transfer happens.
We have to go out drinking before the transfer.
Yeah, exactly.
After.
You're right. I'm definitely not doing whiskey. Exactly. So I mean, I think that when you think about that, and it's like, wow, some of our patients, if they wait 6 months or 2 months, it's the difference between their egg and a donor egg. And those types of scenarios, I think, are really difficult, with that language. And, we know this with so many things. Language is everything.
Yeah.
Word choice is everything. And so, we're advocating, just so everybody knows, we are advocating for everything staying open. And it is a totally different world today than it was in the beginning of the pandemic when we had no idea what therapeutics could work. And so the death rate is way down, even though infections are way up. We're not out of the woods until we have a vaccine.
We
couldn't. You're right. We couldn't even test
what they had.
It's
and
so
now,
true.
Obviously, testing is not perfect, but we are in a much better situation. We do have a lot more clarity, and having the ability to test can make an enormous difference. So right now, we're cautiously optimistic. So everybody in New Jersey that's been asking, stay cautious. I think there's a lot of reasons to be cautiously optimistic. I don't think you should dilly-dally, but I don't think you should feel panicked.
Yeah,
either.
Agreed. Yeah, agreed. All right, we've got some great questions coming in. Waiting for baby Nastasi, I think, Nastasi. What are good uterus measurements from a SHG/SIS? Do you know what that means?
Saline, sono, histogram, saline infusion, sonogram. Those are a couple.
Okay,
little
good.
acronyms.
Thank you for breaking those acronyms down. SHG and CIS. That's what I saw. CIS.
Yeah.
All right. So, what are good uterus measurements from that?
I'm not sure what we're talking about with measurements. Usually with SIS and saline sonogram, I am looking for a cavity that does not have any filling defects. So usually what you see is that the uterus is gray. You'll see it on ultrasound, it looks gray. And when you infuse the salt water, it looks perfectly black. And the black inside the cavity should have a very smooth outline. And if there's lumps or bumps poking into the black, we call those filling defects. And then we suspect things like scar tissue, polyps, and fibroids. And so if you have a lumpy, bumpy SIS, saline hysterosonogram, that's when we think, okay, maybe you need a hysteroscopy to check out, what's going on. Is the cavity okay?
Got it. Okay. Now, if the scar tissue is in like a perfect area that is probably from a C-section or something like that, do you still have to go to the next step?
Yeah, no, we see C-section scars all the time.
Yeah, and, okay. And you can distinguish that.
Yeah, and that area just might be a little bit narrower, like there's a little tiny divot, and it's not something that we feel clinically interferes with implantation rates. You kind of want implantation to take place away from the scar. It might affect your OB's decision whether or not to let you do a vaginal birth after C-section.
Sure. Okay, great. Is bleeding after IUI normal? So Kelsey just did her IUI, so is it normal? Okay.
Totally normal. It can be just from the IUI itself, the little catheter touching the cervix, but sometimes when you actually release the egg, your estrogen drops a little bit, and that can cause a little bit of bleeding, and that's totally normal.
Okay. Her first cycle, she had a chemical pregnancy. Today she's day 5. She's bleeding again, but not as much as a period, but she still feels like it's quite a bit. If it feels like it's quite a bit, should she call her doctor? Should she be seen?
Yeah,
okay.
Call your nurse. See what she thinks. Yeah.
Okay, great. All right. Hi, everybody. Broxy Baby, Sid, Fertility Solutions, SSA, Mamic, Natalie, good to see you. 50 Shades of Jazz. That's such a cute handle.
Cute.
Frenchie Jen. I know, and I love Frenchie Jen, too. Hey, Lauren. Baby Destrine. So progesterone 187 on day 3 after egg collection. Had a 5-day transfer. Will this affect implantation success?
183 sounds really high, but what are the units?
Oh, yeah. Good question. What are the units?
But your progesterone
and we need progesterone.
Your
we need
progesterone is
progesterone.
supposed to be high.
Right. If you're right, you need progesterone for the implantation success. And Serena,
if there's any concern though, you could always freeze. So I definitely worth a conversation. I would talk with your physician because every lab is a little bit different about what parameters they're looking for to create the ideal environment. So I really think you should check.
Okay. All right. Got it. And do you guys, we talked a lot about progesterone and the different types last week. I think it was just last week, right? It always feels like a year ago. Yes, I think it was last week. But, is it always standard protocol for your practice to do, is it 6 weeks or 9 weeks of progesterone injections?
We vary. So
okay.
Typically we start testing and weaning people at 8.5 weeks of pregnancy, which is 6.5 weeks of progesterone for the whole cycle.
Got it. Okay.
So,
and that's usually when the placenta is taking over,
like
right?
egg donation cycles, I tend to be super conservative and go to 12 to 14 weeks of pregnancy.
Got it. Okay. That's helpful. All right, let's see. So Sid just did her first trigger shot. Yay. Good. Congratulations. She took letrozole as well this month. Any recommendations on what to do to cope with the stress of this? Oh, yeah. We've talked a lot about the stress of it and a lot of self-care. We've got some really good episodes on IGTV about all the self-care we recommend.
But definitely plenty of water, plenty of sleep, and healthy food. Very important.
Melatonin's good during this time too, right?
We actually use melatonin a little bit during our IVF cycles. Theoretically, it acts like an antioxidant and might be a little bit helpful.
Right.
But melatonin is not recommended during pregnancy, so I usually stop before the embryo transfer. That's a good question. I'm not totally sure.
But, I want to look that up because it's also recommended as a prophylactic against, COVID, especially since it reduces your cortisol levels. And I wasn't taking it during my first pregnancy, but I sure would like to in my second pregnancy.
Reason, a lot of OBs don't like it. They would prefer Benadryl or Unisom.
You gotta be kidding me. Really?
Yeah.
Benadryl
and Unisom. Those are like our
crazy,
favorite.
But they're so manufactured.
Yeah.
It's like they're so much more chemical than, melatonin.
Yeah. The melatonin, I don't know how it's a pineal gland hormone, and how does it impact the hypothalamic pituitary axis? Maybe that's the reason. I'm not really sure. Or also, how does it cross the placenta?
Sure.
Those are all.
You might have a really chill kid.
And like
you might have a good sleeper. You might have a good newborn sleeper.
Maybe. I don't know. I just really know a lot of my OB friends just like they all tell me they tell their patients no melatonin. So maybe I'll try to do a little researching.
Oh my gosh. All right. Well, I'm gonna email my OB right away too to ask about that myself because that's one of my pandemic coping strategies. I've done so great on melatonin.
I feel like you can adjust your own intrinsic melatonin secretion patterns. This is where my whole thing of doing the blue light filters.
Yeah.
And
I've got blue light filter on these.
That you get the 30 to 60 minutes of outdoor light each morning, or the seasonal affective disorder light. I think that is
I did get one.
Yeah, that's kind of
a
more natural way. Yeah.
So this is my little SAD light. I'm also moving to North Idaho in a month, so it's pretty bright.
That's cute.
But I have one for my son, so when he hops on his computer, he also has blue light glasses now, and he does that for his 20 minutes as well.
Like that might be like a natural way to boost your own melatonin level.
That makes perfect sense. I mean, it does. I mean, it's the whole, it also stimulates the serotonin, which is the serotonin, right, melatonin connection of the two. So I absolutely feel more energy when I use it throughout the day.
Yeah.
Just with the 20 minutes. I do notice a much better energy level.
I've only been doing 20 or 30 minutes also. And it's I feel I'm definitely sleeping a little bit better. So
me too. Yeah, my sleep quality is definitely better.
And then this might not impact melatonin, but certainly impacts the insulin access and definitely impacts sleep. It's this whole thing of late eating. Our whole culture is built around late big meals, and if we can shift our calories earlier in the day and try to avoid eating for 3 to 4 hours before bed, which I know is challenging because I have a really hard time with this, makes such a huge difference for the quality of sleep.
Okay.
Because if you think about it, if you eat that late, your body is revved up. It raises your body temperature. It raises your heart rate.
Right.
There's a lot of things going on.
Right. Okay, that makes a ton of sense too. We on our Instagram we did episodes with a therapist, episodes with Dr. Raquel, episodes with Organic Conceptions. We do a lot of self-care chats, and so dig into our archives on IGTV as well. Do
you have those on YouTube, Alice?
And we also have them on YouTube as well. Yeah, they're all on YouTube also. And some of our own audience, and our community contributes really great self-care ideas too. We just advocate be selfish with a capital S during this time. Do all the things to keep you relaxed, keep you, I didn't want to say positive because there's no such thing as like staying positive. We did a whole episode on that too. But we just want you to do all the supportive things, whether it's teas or your favorite lotion on your hands or aromatherapy. It's hard to get massages right now.
Just being accommodating with yourself.
Yeah, be very accommodating. That's a great
realizing how much more you have on your plate, even though our entire society is experiencing this pandemic. It affects each one of us individually in really profound ways. And
absolutely.
And I think we have to keep reminding ourselves to just, be a little more forgiving. Take it a little easier on yourself.
That came up when I was interviewing one of our great psychologists, and I was noticing how I used to love cooking. And I mean, love it. I used to love nourishing Dante and I with homemade cooking. I have this amazing kitchen, this very bright, big, beautiful kitchen. I've got all my favorite utensils. I have the best knives. And a month into the pandemic, it's the last thing that I want to do.
You just didn't have the resources for it, right?
I don't. I don't have the mental, the physical, none of the desire. When work is done, I want to snuggle on the couch with my kid, and I want to order Grubhub. Or Uber Eats, and I want to just open the door and there's dinner, and it's very, very true.
Yeah.
All right, let's see. So Jen Lucas asking such a great question. And this totally varies practice to practice. When should she resume normal activity after embryo transfer?
Right away. Normal activity right away. So this is what I tell all my patients. There's actually a huge study, really well-controlled, wonderful study. I think it was done in Spain a few years ago, and it was all donor egg, and just one doctor who is very, very busy did they have very high-value programs in Spain. And they did this, 20 minutes of rest versus just getting up and walking down the hallway and going to the bathroom. And the walking down the hallway, going to the bathroom statistically significantly increased chance for implantation.
Wow.
And then there's also apparently some studies of resting after IUI. I think those studies were not quite as big or as well controlled, but there was a trend towards higher pregnancy rates in the get up and go group. So I always tell people, just get up and go. It's the same with sex, IUI, embryo transfer. We have a tremendous amount of data showing that resting does not make a difference.
Okay.
We transfer these little embryos in a tiny little micro droplet of fluid, which as soon as it hits the uterus, the uterus is like a little sponge. It like sucks away all the fluid, so it's held in there by suction. And you have to remember, when you stand up, when you're resting, the uterus is sometimes actually pointing down towards the vagina or up. And when you're standing, the uterus, typically the vagina sits like this, down towards the ground, but the uterus typically is like this, transverse. So it's not even, this where people feel like, oh my gosh, everything's dropping out. But the bottom line is there's no data to support the resting. Now, having said this, okay, I don't know how many husbands or partners, male partners are listening, but I always tell my patients, if you want to tell your guy that Dr. Chen said you can't do any housework for the next month, I got you covered. Okay?
I love that.
I'm with you, girl.
So, when I did my first transfer, 8 years, it's been almost 8 years to the day. In fact, I might be doing my second transfer on like the exact same day that I did Dante. So I had to have a whole conversation with him about sharing his birthday just because of the timing of everything. And he said he's fine with that. He thought it would be fun. Well, he did do rest. And it was 48 hours of bed rest, and I'm like, that there's no way I could even do that right now. I can't have a 7-year-old and run this company and do all and have all these pets. It's not practical. Yeah. So and it's not like for
Now, having said that, you could treat yourself to a day off of work and relaxing and being nice to yourself.
Oh, sure, I can Netflix it. Oh yeah.
Don't be lying on your back. You move around and
don't panic when you go to the bathroom. I think that's so much of it is that for those of us, right? We panic.
A little leaking, like the mucus or something. Yeah. Sometimes we put a little fluid in there to clear out the mucus, and just the catheter touching the cervix often can set off a little bit of bleeding. So all of that's totally normal.
Sure. Even when I got my PAP, same thing happened.
Yeah, exactly.
Yeah. Okay, Frenchie Jen, following up from last week's question, she had 3 mature follicles. We talked about this last week. Clomid Menopur was used. She's 14 days post testing negative, but still no period. She's usually right on time. Do these meds usually delay period?
Now, usually 14 days. So it could be up to 7 days delay, but 14 days, you need to get a pregnancy test and see and an ultrasound and see what's going on. You have to go in and just see what's happening.
Okay. All right. Good advice. See, that's why we do this. Okay. These are 11, cute, handle 2. How many times when you try Femara with no ovulation success before switching to clomid?
Okay. So I would, number one, there's a lot of data for stepping up in the same cycle without any withdrawal bleed. So you try 2.5 for 5 days and give it a couple weeks, to day 21 at least. Make sure that there's no follicle, and then go 5 milligrams a day for 5 days. Again, give it a couple weeks. Ideal if there's monitoring to see, exactly what's going on. Because if there's a little follicle but it's not releasing, you could give HCG or Ovidrug to release the egg. Because a lot of people will have at least partial development, and sometimes they just need that little shove to get over the edge. And then you could go 7.5 for 5 days.
With no bleed in between, you're saying?
No bleed in between. The data shows that no withdrawal bleed in between, the stepping up actually seems to work better.
Got it.
If you have anovulation and PCO, before I would try clomid, I would maybe add ovasitol and maybe add metformin. Now, the thing about ovasitol and metformin really impacting your response to letrozole, you might need to be on it for 1 to 3, maybe even more months before you see the maximal benefit of ovasitol and metformin. Healthy weight loss might be helpful if you have a lot of excess weight. And then you can also think about going, 7 days on these medicines. And, or you could try clomid, but with clomid, I would definitely start with the lowest dose because clomid at higher doses really makes the lining thin. So there's a lot of different approaches. There's no but you have options, because usually doing all these creative things will very much help with ovulation. A lot of doctors like to add a little dexamethasone as well, because dexamethasone seems to lower androgen levels from the adrenals, and sometimes that can be helpful as well, although dexamethasone can obviously disrupt your sleep a little bit, raise your sugar levels, so you have to use it sparingly and just monitor.
I mean, that's also been a game changer in COVID deaths, dexamethasone. The anti-inflammatory.
We're talking just a little tiny dose.
No, tiny dose. Yeah. Okay. Almost like microdosing. Okay.
Yeah.
Waiting for baby. The results posted in her online chart about her uterus. It just said length was 30.2 and height 22.6, but no unit measurement or explanation. But you're saying size doesn't matter in this case. It's not the size of the uterus.
That sounds like normal size, but that's not why we do the test.
Yeah, right, exactly.
We're doing the test to try to look inside the uterus. But the length measurements, it's like usually that's done by a radiologist. The radiologist that's part of the report. They stick it in there, but it's not necessary.
It's not significant. Yeah, got it. Okay. So Frenchie's just clarifying. She was supposed to start her period on Saturday, so she's late, but not by a lot. So
okay,
2 days late. So you're saying
you can give it up to a week as long as you're feeling fine.
Yeah. But
you should check in with your nurse or your doctor. It's always good to just let them know what's going on.
Yeah, exactly. And pregnancy could be the culprit, which would be a good thing.
No.
Yeah. Baby death dreams had the transfer already. Well, fingers crossed for you. Congratulations on getting to that big step, and keep us posted. We certainly hope that it is the positive outcome you seek. Let's see. So many saying hi to everybody. Lots of highs. You're welcome, Sid. Okay, let's see
everybody.
Here. Yeah, Janelle, Kay, Abby, Oh My Yoga. So many people say hi to. I'm waving to everybody. Keep your questions coming. All right, here's another question. Okay, large fibroids, one possibly attached or blocked endometrium. Could that cause fertility problems?
Yes, that could. It seems like might be what's called a submucous fibroid, so where the fibroid is actually inside the uterine cavity, and the surface of the lining over those fibroids really tends to be very abnormal appearing, tends to be very inflammatory, and possibly affects implantation, affects the attachment of the placenta, is associated with higher rates of miscarriage, and usually with a skilled operator is relatively easy to remove in a simple outpatient surgery where we just shave it down without any incision.
Interesting.
Just go through the vagina. So that might be something you should talk about with your doctor.
That's great. Okay. We have one question that came in too. I always forget that there's that private question screen that comes in as well. So there is someone who has had egg collection today. She is in a lot of pain with her ovaries and across the bottom of her stomach, but she also has endometriosis and wants to know if it's normal.
I think if you're having more pain than normal, then you definitely have to get checked out. So I would call your gynecologist. One thing we worry about with endometriosis that can actually be dangerous is ectopic pregnancy.
She did her egg retrieval today.
She did her egg retrieval.
Yeah, she did her egg retrieval today. So, I mean, a little pain is normal, especially if they collected a lot of eggs. But if she's uncomfortable with it, I feel like call the nurse.
Yeah,
right?
That's what I would say. But usually, you could take some Tylenol, as long as you tolerate Tylenol, lots and lots of water, and get some rest.
Right.
But yeah, you should check in with the nurse just to make sure.
Yeah, exactly. I do remember when I felt like my stomach was huge. They retrieved 31 eggs, and I was 31 at the time, so it was high volume, but I also was younger. And I just remember just feeling so bloated. Yeah. And, they were definitely kind of watching me to make sure I wasn't hyperstimmed or anything, right, which happens.
Right. I have to say hi to Jake because Jake is here. He just stopped by to say hello.
Oh, good. Hi, Jake. That's awesome. All right. Hopefully it helped a little bit. But, when in doubt, always call the nurse, on things like that because it's an active situation right now. It's not, if you're uncomfortable with the pain, call.
If you think, should I is this okay? I think you just got to call. That's
right.
the safest thing.
Right. Okay. Lauren is asking a great question about vitamin D levels. Her prenatal already has 400 IU, which is sort of standard in most vitamin Ds. But after blood work, her doctor wants her to up it to 2,000 IU, and she's wondering, is that too much in addition to what's already in the prenatal?
No, 400 is very little. Most,
very
at
low.
least in the Northeast, people who are only on 400 milligrams a day, usually or 400 IU a day, which is totally different in micrograms. I forget exactly what it is, but 400 is very standard, and it is definitely not enough for people in New Jersey, at least. You know, we have almost 100% prevalence of vitamin D deficiency on those kinds of doses, and 2,000 is not that much. Typically, I find, at least in New Jersey, a lot of my patients need 4,000 to 8,000 a day during the winter. So I think add the 2,000 and maybe ask your doctor if you can get your levels checked in a few months.
Exactly, checked. Right. I mean, just also perspective, when I was diagnosed with breast cancer 13 years ago, my level was a 6. I was incredibly deficient. Yep, I was incredibly deficient. And I so low, and I lived at the beach, and I'm not an avid sunscreen use person. Like I'm the kind of person I would like. I have a metabolic issue with it, and so they put me on 50,000 per week, 50,000 just to give you guys perspective. And being on that for years, and I'm still only like a 30. I struggle so much to get my levels up.
So Alice, you have to look at your label. Are you taking D3 or D2?
It's a prescription.
Yeah, prescription is usually D2. And what I find is people like you who struggle to get their levels up, you might actually do better
with D3.
Forgetting about the prescription and doing D3 over the counter.
Interesting. All right, I'll try that. Yeah, I'm getting a new level on Friday.
I think if you're always at 30, you could easily add like 3,000 to 6,000 D3 a day.
Right.
And
okay.
See how you do. I bet.
What's the difference between D2 and D3 anyway?
D3 is the end product, the active hormone. D2 is the pre-hormone, and if you have a processing issue,
then exactly.
Then I just can't process the D2.
Totally. That makes complete sense. Yeah. All right. Caitlin's asking a question that I feel like a lot of people ask this question, and so it bears us answering over and over again. It's this whole idea of tilted uterus. And what
everybody asks about that.
Yep, everybody does.
Uteruses are usually tilted a little bit. Like usually you always have, the vagina is this way and the uterus is this way. And when it's like being right-handed and left-handed, or having black hair and red hair. Red hair is less common, but it doesn't mean it's bad.
Yeah,
so typically when the uterus is tilted a little bit towards the front of your body. That's called anteverted. And so that's tilted, but the doctor will not tell you have a tilted uterus because that's the most common tilt.
I see.
So if you're tilted backwards, since that's a lot less common, and it makes it harder for the doctor to insert the speculum and see your cervix, then the doctor will tell you it's tilted. Also, the doctor wants to make themselves look good and not like they're struggling. So then, we blame the patient. Oh, you have a tilted uterus. That's why I'm having trouble seeing your cervix. So that's just our little secret here.
Okay,
don't tell anybody.
So there's nothing to do after transfer or after
There is
sex?
nothing to do. It does not affect your fertility. Now, having said that, if you have severe endometriosis and the back of your uterus is stuck backwards, sometimes you will have an extremely retroverted uterus, and sometimes a uterus that is tilted and stuck and scarred is a sign of endometriosis. You can't say that tilting alone is a bad thing.
Because we all have tilt. We all have tilt. Okay, got it. Yeah, this does come up a lot, Caitlin. You're so not alone. We have, everybody asks this particular question because it's like the word tilted uterus is thrown around so much. And so I think it's a really important one. Thanks for answering. All right, Shelly is asking, if HCG has gone back to 0 tomorrow, are there any questions she should discuss with her doctor to get prepared for another transfer?
So usually ask your doctor, should you have another saline sonogram, just to check to make sure the coast is clear. And what did they think of how your lining looked during the cycle? You know, like it's always a chance to Monday morning quarterback a little bit and to just say, were there any obvious reasons for concern? The vast majority of the time,
right,
there are no reasons for concern. And we know that just the more times you try, the better chance you have of getting to the baby. And most of the time, it's just a matter of trying enough times. But this is your chance. Talk to the doctor and say, you know, could we do anything better? Is there anything I should be doing? Is there anything more information you feel like you should have? Like, what else should we do?
Got it. Okay, great. We have a question coming in from Purple Butterfly Magic, and I actually have a question in response to her question for the whole community that's live right now that I want answered. I'm going to do a quick focus group. So we see this question also all the time on the app, right? We're Fertility Answers app, and for those of you who are kind of new to us in our community, we have a Fertility Answers app. We have 400 experts who will answer your questions for free, just like Serena comes on and does Ask Me Anything for free. We do this. And what we've noticed is that a lot of women are like Purple Butterfly Magic, another cute, super cute handle, who she's been trying to conceive for 3 years, 3 whole years. No true complete fertility workup, really. Like, we see it all the time. People have struggled for that long, and they haven't seen a fertility specialist, and they haven't gotten what we would consider a complete fertility workup, right? And so my question to the community, because she wants to know what to do next, and I know what Serena's going to say, and I know what I'm going to say, and we're going to say you need to get in for a full workup, and, you know, you have to figure out what's going on, and you know,
information is power.
Yeah, and we, like, you know, I've got to drive to Idaho in a month from Los Angeles. I'm not going to do that without getting my car completely checked out. I'm not even getting on the road. And yet, as a society, we suffer for years not getting what we want in life without getting into this particular specialist. But who goes 3 years with horrible back pain without getting into a back specialist? Who goes, you know, 3 years with ridiculously high blood pressure without getting into a cardiologist for a workup, right? They're like, who, you know.
I think it reflects a lot of the, you know, kind of the shame and secrecy and stigma that surrounds reproduction and,
like,
you know, quote unquote, women's issues. Like, we don't value those problems enough, and yet reproduction is responsible for the continuation of the human race. It is really, really frustrating.
It is frustrating because it's not
feel really comfortable.
That's right.
And getting help, and help should be easier and more accessible.
Yeah. And we also, you know, don't like seeing people get sort of treated by their general OBGYN. It doesn't happen all the time, but it does happen a lot, you know, with sort of a stand-in for a specialist, but they're not a specialist. And so it's just keep trying. There's nothing wrong with you, right? I did your labs and everything looks fine, but they don't run all the labs. They don't have the 2 extra years of fellowship training that these IVF doctors do have. But I almost feel like we need to rename your profession. We loosely call you IVF specialist, but that's not your specialty. And it's not about IVF. It's about treating infertility. Right. It's about helping people
and reproductive health.
And reproductive health. And so I think that there's that. But my question to this audience that I would love to answer is, does it just feel so overwhelming to, like, make a big appointment, right? To go in, and it's usually an hour consult. It involves labs and usually an ultrasound, you know, scan. And we really feel like on our app, we want to release a feature where we allow you to connect with these folks for $30 or $40 for 15, 20 minutes. You know, do you need that interim step where you just get to have a quick, you know, short one-on-one conversation with Dr. Chen so that she can say, you know, with confidence, okay, you know, I heard a little bit about what's going on. You've struggled for this many years, and here are the next steps that I think you should do. is it overwhelming to have that first consult at an actual clinic because of all that it encompasses? It's a big visit, that first visit. It's not I'm going to pop in and get my pap and ask a few questions and be in and out in 20 minutes. Is that part of why people aren't doing it? I want to kind of know. Like, would you rather have a 15, 20-minute call?
From the physician's perspective, our system is not set up to really spend time really counseling patients, really answering questions. You're right. We got to get in there. We got to get the pap. We got to get out of there. We got to go on to the next patient. We got to write our notes.
Right.
And so your annual visit often has a lot of pressure placed on it. So maybe at your annual visit, you should say, like, there's other things I want to talk about. When can I see you again? Thank you for, okay, I got my pap done. I had to get that done, but I have all this other stuff I need to talk about.
Right.
How can I do that? And now that more people are doing telehealth, hopefully that's helpful. But that's a huge part of why you developed this platform, Alice.
It completely is, and that's why I think we have to roll out 15-minute consults.
Yeah, we can break down these barriers.
Because I think we need the conversation. It's like as much as we can answer questions, it's like answering a question then provokes a follow-up question. Mm-hmm. So we're releasing threads next year, so that you patients can follow up to your answer. We're going to allow that for like 1 or 2 lines, and it's completely free. But I do think that there's some kind of in-between step that I feel like folks, like Purple Butterfly Magic need, where it's not necessarily, she's not yet.
It's not necessarily a full consult, but just maybe some expert direction.
Exactly. I think that's what people are missing is like the actual expert direction, because she shouldn't be going on 3 years and still just talking to her OBGYN about it.
That's way too long.
It's way too long. She definitely needs to talk to a specialist, but she might be thinking, I think I hear this all the time too. Well, I can't afford IVF, so I don't want to go to the IVF doctor. Yeah. That is not the IVF doctors in our network.
Right, because there's so many things we can do to improve your health and your fertility before you ever get to IVF. Maybe you never have to use IVF.
Yes, exactly. And that's really so much about our network, right? And why you make yourself so available, why we have other folks that are so available, is so that for those people who do need IVF, we want you to get in for IVF sooner so we can help you financially, so you can really plan for it, so you can use your own eggs, you can use the youngest eggs possible, right, so that your success is best.
But the truth is that the vast majority of people who struggle with this will not actually need to do IVF.
That's right.
But everybody needs, I think, some good advice.
Everybody needs a specialist, though, who meets the definition of infertility. Yeah. 12 years of trying to conceive and being under the age of 12 months, not 12 years. That sounds like a bad movie title for infertility.
6 to 12 months. Yeah,
6 to 12 months, depending on age, under 35, of course. But if you also have a history of irregular periods, obesity, PCOS, painful periods, right? Pain with sex.
You don't necessarily have to wait to get that advice.
Yes, we don't want you to struggle when you've already been struggling.
Yeah.
And it doesn't mean that you've been struggling specifically to conceive, but you already have been struggling with something that is reproductively focused. So we want you to just get in as fast as possible. So that's really the advice, Purple Butterfly Magic, in a long-winded way, and I would love to hear you guys all, reply back on what your thoughts are, and if you would like that 15, 20-minute consult, if that's what's really missing in your life to get access to the specialist better, because we want to solve it. We arrange this network, we've got great funding, and we want to keep bringing the solutions that you all need. Okay, let's see. We've got, I hope that's helpful. Lauren, you're welcome. We love supporting you. Kay Sushik, I like that. So thank you, doctor, for the answer. The GYN could not give a definite answer, but wants to do a fertility workup and said that if the fibroids are not causing the problems, not to worry. What is that shave procedure that you mentioned, Serena?
It's called hysteroscopy, which hyster is Hyster, that stands for uterus, and SCOPY, scopy, so that means putting a telescope inside the uterus. And there's different technologies that are used to use these high-speed blades to, just shave shave the fibroid down. You do need an expert in that. Not all general OBGYNs do that. There are some OBGYNs that are specially trained. A lot of reproductive endocrinologists are very, very good at this procedure. We do a ton of them. So that's a good place. That's a good way to go. And Alice,
some of our folks, we can find somebody.
Right?
Yeah, we can give you a referral.
Okay.
So if you just DM us, I'll have Latrice help find somebody in your area, but we can find a great specialist for you. Sometimes I even reach out to Serena and say, hey, who do you know that you went to fellowship with in Florida or something? So really anywhere that you are, I can already, we've got a great reproductive surgery practice in Phoenix, Arizona. We've got folks up near Serena too, a little bit more north in Manhattan. So just let us know where you are and we'll help find somebody. So Caitlin's confirming hers is tilted backwards. And so the question would be how much backwards, right? To see if it's a sign of endo.
A little tilted backwards. Like, does your doctor think it's really abnormal or like it's really, really twisted backwards? And like, do they suspect scar tissue or is it just like a little tilted backwards?
Right.
That's what we need to, because a little tilted backwards can be, it's not as common as tilted forwards. But
it's like the red hair
still can be normal
analogy, right? Yeah. Right. It's not. It's runs extremely that you're worried that endometriosis is kind of like stuck there. Yeah, gotcha. All right, Beck's asking a really great question too because we see so many people, myself included, with multiple biochemical pregnancies. So when you see multiple, like for me, I was perfectly capable of getting pregnant 5 different times all by myself without assisted help at all. And loss after loss after loss after loss, like clockwork, the exact same time.
We do not understand biochemical pregnancy very well at all. So biochemical pregnancy is usually very early with a low beta that doesn't turn into a pregnancy where you can actually see the sac. So that's the definition. It's called a biochemical pregnancy because only the pregnancy test is positive.
Right.
You don't see any other evidence of it. And the bottom line is if you look at the normal fertile population, these actually happen all the time. Right. They are super, super common. We don't know exactly how common they are because we're not like, the general population, usually we're not constantly drawing blood.
Sure.
Right, to test. We're not constantly watching, okay, this
and a lot of people have it and they think it's just a heavy period.
Exactly. And so in general, what I see in my practice is that I feel like the vast majority of the time biochemical pregnancy is in many ways a positive sign. It's a positive sign that you had an egg, that it had egg healthy enough to fertilize and an embryo healthy enough to implant and make some HCG, but not healthy enough to carry on further. And I think that's a good sign. And usually to me, that means that we have something to work with. And do I know exactly how we're going to get to the baby?
Not yet.
I don't really know. Maybe just advice, maybe IUI, maybe IVF. But it seems to me that people that can make a biochemical pregnancy should respond to treatment. And I think it is a reason for optimism, even though obviously it's super frustrating that the pregnancy doesn't turn out the way you want it to. Should they be counted as a miscarriage? It's not totally clear. Right. I usually do treat them very conservatively. So if there's 2 in a row, then I would just go ahead and do the little bit of extra blood testing to say, okay, we did the recurrent miscarriage workup, but is it really a recurrent miscarriage issue? I'm not really convinced of that yet.
Yeah, I got you. I do hear a growing number of patients as well whose OBGYNs even will prescribe progesterone supplementation when they see this. I'm seeing that a little bit more regularly.
I don't think there's any downside to progesterone as long as you're watching the patient very carefully, because I always worry, like, if the betas are not normal, we always worry about, tubal pregnancy, because that can really, literally kill you. So, so you have to be watched carefully. You can't just throw somebody on progesterone and then just forget about them.
Exactly.
But I don't think there's any downside.
And I think that's the risk of not being with a fertility specialist, is that your entire practice is set up to monitor people closely. The practice that I'm getting my testing done on Friday, they were there all weekend. there were nurses there on Saturday. There were nurses and doctors on Sunday doing transfers, doing monitoring, doing work. And it's a 7-day-a-week practice, and OBGYN practices are just not set up for that. They're just not set up for the frequent blood work and the frequent scans and things like that. And so even if you were, even if you do want to continue trying unassisted, but maybe a monitored cycle, be willing potentially, right, to pay out of pocket for, some extra attention if you're concerned about it. And especially given your age, we don't know your age. So the older you are, the more concerned we would be. And
right.
we would just say, go to a fertility specialist and get a full workup, anyway. We hate seeing delays. We know the longing so personally and deeply ourselves. And I did, like you, Beck.
And also,
I have 5 of
the
them.
longer you wait, the less options that we have for treating you. So.
Right. And that's why we don't like that either. Yeah. It's just, we don't want you to have fewer options.
We want you to be successful.
Exactly. That's what we want. Let's see. Shelly Davidson. You're welcome. I was getting ready to ask and answer her question, but she said, thank you. And you're welcome. Okay. Gemma, would you transfer 1 or 2 embryos for higher chances of success? This is such an important question. So she's in the UK. They're going to Czech Republic, and she is aware of the risks of twins. She's saying they're the same quality, but I know Serena's answer is going to be the same.
Yeah, no, usually we recommend a single embryo transfer. Now, having said that, like, what if you're like 43 years old and these are day 3 embryos? Then we might say, reasonable to transfer more than 1. So it really depends on your age and the quality of the embryos. If they're day 5, we really like to try to stick with just 1 embryo at a time, unless you're like, 42 or above. Like for 42 or 43 and above, I think it would be okay to transfer more than 1 blast. But
so that brings up a good point though. So I'm 44 and I was only going to do 1 because they're still 31-year-old embryos.
Right. That's different.
Right. That is different. 43. Okay. Yeah. So
then yours are tested. So even if this was a 42-year-old or a 44-year-old with a blast with older eggs. Yeah. That is the same as a 25-year-old blast that's tested. It's the same thing. Once you do the PGT, you have a PGT normal embryo, you're kind of taking age out of the equation.
Yeah, gotcha. Okay. All right. Hopefully that's helpful, Gemma. And I think that the misnomer of transferring 2 embryos is that it leads to higher chances of success, right? That's what they used to say, but it doesn't.
Higher rates of miscarriage. So you do have to be really careful. It's not like an addition problem. It's definitely the data does not support that.
Right. And 8 years ago, even when I did my transfer with Dante, and I did too, it was because that's what they used to say. Yeah. I remember talking to the embryologist, and he said, you have an 87% chance if you put in 2, and you have like a 65% chance with 1. And I was like, okay, let's do 2. And he's like, and you have a 50-50 chance of having twins. And I was like, okay, that's scary, but let's do 2, because I was focused on what he said, but now we know what he said is not true.
Right.
And I think that that's the thing that we're trying to help shift, because we want healthy babies and healthy mamas. And it increases the risk. We need both. And it so increases the risk that, and, we get so upset when we see, patients say, look, I'm going for twins. I got really upset when Paris Hilton came out, and she was so brave and talking about her egg freezing, but she also said, like, oh, I want twins and I can pick a boy or a girl. And I was like, okay, that's just not the total story here.
There's so many things we have to talk about. It sounds like a great plan, but we always have to think about there's 2 sides to that story.
Yeah, exactly.
Very important. Yeah,
exactly.
Think about the risks also. So.
Yeah. Let's see, purple. I think her handle stands for Purple People 57. If I saw it on the license plate, that's what I think it says. Purple People. Remember that one-eyed one? Do you remember that song, Flying Purple People Eater, from when we were kids? Did you know that song? Oh, it was some silly song. It reminds me of that. Okay, I digress. And we're going long, so we'll wrap it up in a second. Can she get pregnant naturally at 45?
It could happen. It's very unusual because typically that's like near the end of the reproductive lifespan, but some people can. It's just really hard to predict. If you honestly, if you're asking that question, that probably means you've been trying for a little bit, and that means you might fit the definition of infertility already. And if you have infertility and you're 45, the chance that our statistics say it's just very tough. The odds are long.
Yeah. And, the thing at 45 too, and I'm right there with you, I'm 44, is the rate of miscarriage is also going up with age. And the rate of chromosomal issues is going up. The risk of Down syndrome is going up with age. So it's not just about, and yes, we all know that one person who's like, oh my gosh, I had a spontaneous pregnancy at 47 and I couldn't believe it. We can't hang all your hope on that one person because it's less than 1%. Likelihood. And so we just really advocate, get in so you learn your options right away, and get checked out. Sydney Chick, questions regarding pregnancy. So we now have a pregnancy category on the app, Sydney. So I think actually it'd be best to ask your pregnancy questions on the app.
Okay.
Yeah, we have a new pregnancy category and some OBs.
Pregnancy answers.
Yeah, well, it's not even pregnancy answers. It's just under the categories of types of questions you can ask, like diagnostics and treatment. We added pregnancy.
Perfect.
So many of our users are on that side now, which is so exciting.
That's awesome.
Yeah. Oh, okay. So, Kay Sushik, I think I'm saying that right. Yes, she's in Oregon. So I've got a great reproductive surgeon for you in Oregon, but please DM me and just remind me that you're the one that needs the fibroid surgery because we get hundreds of people watching and hundreds of people DMing. So just DM FertilityAnswers, and I will make sure that we get you set up with that reproductive surgeon. We've got a great one in Oregon. Yep. Okay. We've got some other questions coming in and and then also, Purple Butterfly said, yes, she actually would like that option of the shorter, consult. Okay, perfect. I think, let's see.
I have to go soon.
I know, me too. And we love you guys so much. We could go forever, but we have to.
Here, but
it's so great.
We'll be here next week.
Okay. All right. This is a good question too. Triggered the 13th. Positive for ovulation test on the 15th. Doctor said to take pregnancy test tomorrow. Is that too early? That's her 2-week wait, so that's perfect.
That sounds perfect.
Yeah, exactly. Okay. Sydney Chick lost weight. Is that okay? How can you tell if the baby's okay? Oh, so these are some of her questions. Chest pain, normal. You got to call your doctor, honey. Yeah.
Yeah, chest pain, you have to call the doctor.
Yeah.
Losing weight in the first trimester sometimes can be normal.
Yeah, especially if you had a lot of morning sickness, that can be normal. But if you have chest pain, you got to call right now.
Yeah.
Get off of this and call. You need to call your doctor. Okay. All right. Beck's only 25. So, Beck, I think, you're young and having that many biochemicals, I would get checked out.
Yeah.
Because you have time to optimize. You could work with Dr. Raquel nutritionally. Dr. Raquel can look at your heavy metals. She can look at gut microbiome. There's some other things, that you can do. Like that she's got time to really optimize. My battery notification said you're low. Sorry about that, everybody. But what we mean is that time is on her side because she is 25, so she doesn't have to rush into IVF. If she was 35, we'd probably well, let's actually, consider a more controlled outcome, a more controlled process. But at 25, she does have a little bit of, she has more of a window to kind of optimize things and really work with the right specialty team and maybe include a naturopathic fertility doc to do a complete workup and really see what's going on to see if we can help her achieve success with assistance, but very low tech.
Running out of battery.
I know I was on Do Not Disturb, but somebody called twice. Okay, so let's just see. All these other questions come back, and on Monday, next Monday, and let's ask them again. I don't want to leave you guys hanging, but also Serena has to go and do it. And also you can ask all these same questions on the Fertility Answers app, and not just Serena, but a lot of other eyeballs will get on them.
24/7.
Yeah, it is. It's 24/7. We have people all over the world.